I'd like to thank MRA, Cody, and BMS and others for allowing me to give this talk. Few people know that when I came out of fellowship, I was at USC and was tasked with working in the melanoma clinic and working in the primary brain malignancy clinic. And at that time, I learned a lot about how to take care of not just primary brain cancers, but brain metastases. But when I would give a talk, it would take forever. I could not find the slides. I could not find the information. And there wasn't much to say about melanoma and brain mets. But I'm fortunate to say that today there's too many slides. There's too much. From what we have gotten from treating metastatic melanoma, finding out about mutations, and the next generation therapies, we have an armamentarium that is phenomenal and is helping us come to make the right decisions and come to answers. And ultimately, what this has brought forth for us is the ability to go to any pharmaceutical partner and show a history of success, of showing that it works in metastatic and then in brain. So for me, it's a continuum now. These are my disclosures. When you sit in a room with a patient with melanoma who's newly diagnosed or who's been diagnosed with brain metastases or leptomeningeal disease, you try to talk in a very mild fashion, but there's always a big pink elephant in the room. And you sit there calmly and the patient is calm, but the outcomes with brain metastases were so poor, weeks, couple months, that you tried to shy away from it, and it became very difficult to find the right answers. And by the end, I'll convince you that this pink elephant is not that difficult to deal with. This is a great article in Cancer in the late 70s, autopsy studies, which we don't do enough of. But it showed that, upon diagnosis, about 40% of patients with melanoma had some brain mets, and autopsy studies showed 75%. And then the leptomeningeal contribution was like 33%. So it's a huge problem, and it's true what Mike Atkins said, that there are patients who, even on MRI, don't show but may have subclinical brain metastases, so it's important to take care of it. Thankfully now we have an armamentarium. This is a comparison of pipelines in 2017 versus 2020. And based on our clinical program where we were dying for trials and now we're turning trials away because there's so much, and we don't have enough patients, there's astronomical growth, and all of these can be used for brain metastases. I'll thank Dr. Bookbinder for allowing me to speak before her and apologize for speaking on some things that she will delve into in a greater fashion. I'm just going to show you that it really works in the brain. And targeted therapy, although Dr. Atkins showed you that it works, but the response is short-lived, can be leveraged for a great benefit in our patients that have metastases inside the brain or leptomeningeal disease, which is metastases to the covering of the brain and the spine. This is COMBI-MB from Mike Davies and others, showing that if you give combination of BRAF and MEK inhibitors, you get a response rate that is correlative to what you see in the body. Unfortunately, what you don't see is a similar progression-free survival. The durability of response is almost half. So what do we take from that, and what can we do with that, is the idea of being able to control significant symptomatic disease that does not allow you to get to immunotherapy, which will give you the long-term benefits. If you can get rapid control either through surgery or through radiation or even through BRAF inhibitors, you can then transition. And the background to this, and I didn't put this slide in because there's too many slides, comes from data from a good friend of ours, Paulo Acierto, who did a Sagambit study in metastatic melanoma, where you started with BRAF inhibitors for just 8 weeks to control disease, and then went on to immunotherapy combinations and showed better survivals than if you just put on targeted agents and waited for progression. So this, for me, is for those patients who harbor a BRAF mutation and are symptomatic, have rapidly growing disease, or we need to control before we go to immunotherapy. A short burst is helpful. Of course, I don't go till 5.6 months because I know there's progression. What else you need to know? That there are multiple genes mutated in melanoma. There are, I forget the number, 70 to 80% of patients harbor something other than BRAF, and they are targetable. We know this because we see it work in other solid tumors, whether it's ERB-B3 or ALK or IDH, HRAS, or other mutations. These inhibitors have been shown in other solid tumors to cause tumor regression and to cross the blood-brain barrier. How do I know that? Well, here. This is a pan-TRK ROS1 and ALK inhibitor and entrectinib. And this was a clinical trial that took all comers. And this is a patient with melanoma that had response. Now, I'm not saying that this is the answer for everyone, but when you think that you don't have options, every patient that comes to our clinics gets a next generation sequencing, and there can be an option. And there are trials. We currently have a trial through ASCO, it's a taper, that gives these targeted agents to other solid tumors that don't have these options and allows patients with with asymptomatic brain metastases. We're also utilizing information to tell us what we should be doing and where things could be going, and if there are mutations we're missing. Circulating tumor DNA is a tumor DNA that's shed in your blood, and there are multiple tests that you can get commercially to check for that. You can also look at that in the CSF, and there are tests that are coming and trials that are looking at monitoring that, looking for a tumor that has spread from an original area or from a metastasis that may have picked up a mutation we don't know about. And this is being utilized significantly in the neuro-oncology setting. One of the findings that I came across is that dealing with brain metastases used to be the job of the neuro-oncologist, someone who was either trained in oncology, neurology, or even pediatrics, and became a neuro-oncologist, and we sent our patients there. And this information was sort of miscommunicated or lost, but all oncologists now are neuro-oncologists and can treat patients. What about checkpoint inhibitor therapy? This is the data with anti-CTLA-4 and anti-PD-1, and also the BRAF and MEK. But what you're seeing here, and this is Checkmate 204, and I was telling Dr. Bookbinder that for all patients, I'm going to put a registry and I'm going to name these studies, and they're not going to be like checkmates. We're going to give them names that we know what they are, like I was on the Sparkle study or whatever. But this study, so that we can all communicate appropriately, this study was wonderful. Why? Because it kept patients coming to my clinic. And we have patients here that showed about a 55% response rate, and that response was durable. How do I know that? It's the tail of the curve. And Checkmate 204, upper right corner, you see that tail of the curve? It continues, and I have patients 5 or nearly 10 years out. So the backbone of an immunotherapy with a PD-1 or PD-1 CTLA-4 is important here. And we're building, here's the tail of the curve, we're building other combinations. As we speak, in our clinics, we have triplet. Actually, it's a quadruplet. It's the anti-LAG3, which is relatlimab, anti-PD-1, which is nivolumab, anti-CTLA-4, ipilimumab, plus an IL-6 inhibitor in non-brain mets. But if it works well, we see low toxicity. Guess what? There's going to be a brain met study coming. And we're also, this is leptomeningeal disease data that comes from Ryan Sullivan. All of you know Ryan. He's a MRA investigator. But we're also looking at genomic and transcriptome correlates of immunotherapy response within the microenvironment, looking at CSF and tumor tissue from resections. What about radiation? This is my only radiation slide. I'm so happy to say that we've moved away from whole brain radiation because immunotherapy and targeted therapy can control disease. I never begin by telling anyone to go to whole brain radiation. We use spot welding with what you call just gamma knife radiation or SRS or SBRT. They all mean the same. But this was an interesting study that came out. It's a randomized phase 2 trial of proton craniospinal irradiation, so the brain and the spine for the hardest melanoma to treat, leptomeningeal disease, but this was melanoma, lung cancer, and breast cancer versus just spot welding those areas in the leptomeninges. And there was a better overall survival that was significant in lung and breast, and we're looking forward to the other solid tumor data. We're also improving on the immunotherapy, and we're improving on PD-1 and CTLA-4. We're trying to find drugs that work better, that bind better, that you can dose higher with less toxicity. And this is a bispecific antibody, MEDI5752. That needs a different name, unicorn or something. But this was a bispecific antibody that we found binds better, faster to CTLA-4, and binds less to other target cells, so less toxicity. And there is no reason that these things cannot cross the blood-brain barrier. And we're going to find that out. And this is a trial written by Adil Daoud, who's at UCSF. Adil runs a great program, and we're fortunate to collaborate with him. But what's interesting here, it's not one, not two, not three, but four. 4 drugs, 2 bispecific, CTLA-4, LAG-3, PD-1 and ICOS, so 4 checkpoints together. It's looking at metastatic melanoma and looking at brain disease, so we'll look into that. One of the targets we don't talk about is VEGF, antivascular agents that are big in other cancers, Avastin you might have heard of and others. And these are very helpful in the central nervous system. I put this slide up because this is a VEGF targeted agent that has a compendium approval for second-line melanoma, lenvatinib. And lenvatinib and Keytruda here, or pembrolizumab, it's approved for other solid tumors. It's endometrial cancer, it's approved. And lenvatinib has shown great responses in melanoma that's heavily pretreated with checkpoint and other therapies, and is now finished the randomized phase 3 in the first line, and hopefully it'll be at the earlier part of Dr. Atkins' talk next year, not at the end of Dr. Atkins' talk. But these agents help because they decrease the swelling from tumors. They decrease the shift of brain metastases. They allow for immunotherapy to work, and blocking VEGF can boost immunotherapy. We know that high VEGF levels are a poor prognosis. They affect dendritic cell function and immune function, etc. What else? Well, how about directly given therapy into the brain, into the CSF? This is Isabella Glitza, who's a great friend and works at MD Anderson. She's my friend at MD Anderson Cancer Center. Everyone references Hussein Taubi these days. But Dr. Glitza has done an amazing trial of looking at intrathecal nivolumab. We know that giving these drugs in small units directly into tumor works. There have been trials of directly injecting PD-1, directly injecting anti-CTLA-4 into tumors that are in lymph nodes or skin, and there's been response. Why not directly into the central nervous system, into the CSF? Dr. Glitza has informed me that she has completed this trial, and there'll be a publication coming soon, but they've seen responses and durable responses for many, many weeks and months in patients who you would have lost within 4 to 6 weeks. And this is a great slide because if you follow it on the left-hand side, I got to do like this. If you follow it on the left-hand side, this patient had everything. Radiation, Temodar, ipilimumab, nivolumab, blah, 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 and failed it, and then went on to just giving intrathecal nivolumab, and has 50 cycles. Look at the dates down there, 6/20/18 to 4/20/20, and I'm not moved by this. It's the same slides that Jed Wolchuk showed with metastatic disease outside of the central nervous system. So we knew these drugs could work, and we know that there's evidence that they can cross the blood-brain barrier. There's evidence that we can give it directly into the brain. I'm just going to transition now into cellular therapies because these are all the rage now in melanoma. CAR T, adoptive T-cell therapy, bispecific, the ImmTACs that like tebentafusp, and I'm just going to hit on them a little bit. But there are so many new trials and new therapies. So there can never be a patient with melanoma that says there isn't a trial that's appropriate. So adoptive T-cell therapy, quickly, you get the tumor, you take it out, you tumor digest it, you find the T-cells that are specific for the tumor, and you grow them. That's called the rapid expansion, and you put them in a bag. Before, it used to only happen in a couple of areas, and now there are trials where they do it centrally, and they send it back to you, and you give it. How do I know? Because I work in a small clinic. Academics call me a private practice doc. Private practice docs call me an academic, but I would tell you that I'm a hybrid, and that's where a lot of local regional care should go into academic private hybrid docs. But we gave this, and we were good contributors to the Iovance trials. So the patient comes in, gets a chemotherapeutic regimen not targeted at the tumor, but to get rid of the other T cells. You give them their single infusion of their billions of TILs, and then you give some IL-2 to aggravate the immune system. So IL-2 still has a big place in melanoma. And what have we seen? This is John Hannon's data of second-line post-PD-1 with higher response rates to TIL therapy than giving anti-CTLA-4 therapy and a better survival. And this was in the New England Journal of Medicine, so you know it's true. And this is the Iovance data that was presented where it was throughout the nation. It was a blend of trial sites that were in the community, that were in academic centers. And what I want to bring your attention to is there were responses. There were early responses. Those blue diamonds are patients who had an initial response, and you can see they happened very early. They were durable. Some people went from stable disease to partial response. Some people went from partial response to having everything clear out, and the durability is great. But if you look at that big red square around there, the majority of patients who were on this trial and the majority of patients who responded, their best response to checkpoint therapy was progressive disease. So we're finding therapies that work when our standards don't work, when our checkpoints don't work, and they were durable. And you see a very robust survival, and 80% of patients had seen CTLA-4. The patients who had BRAF mutations had already seen BRAF therapy, et cetera. But I bring you to this, and that there's data presented from, in the NIH, Steve Rosenberg's data and others, where patients with brain metastases showed response, brain metastases showing response. And currently, this is Alison Betoff-Warner, who was at Memorial and has just started at Stanford. And she works with Susan Sweater, who's a big MRA investigator. So Dr. Betoff-Warner is now running a trial in patients with brain metastases looking for adoptive T-cell therapy. And this is the real deal. These are first-line patients who are being treated with combination of PD-1 and TIL, and it looks good. These are waterfall plots. I always have to reorient myself. Going down, those lines going down is good, and you see a lot of it going down. And you find the one tenet of what I say to any oncologist, that the data that we are deriving for our patients in melanoma are important not just for our patients for melanoma. You're not advocating for a small group of patients. When we published the Keytruda data, it was in melanoma and lung cancer, and now as I stand here, I can't even think about the number of solid tumors where anti-PD-1 has a first-line indication. Gastric, esophageal, Merkel, cutaneous, lung, renal, gyne, etc. So we're finding that head and neck, it works for head and neck, cervical. So these therapies are going to revolutionize how we take care of patients, not just with melanoma, but hard to treat patients. And tumors that are a global issue, like cervical cancer, global issue. All right, what about CAR T therapy? This one doesn't require surgery. You take you pherese the T cells out, you add a homing mechanism, like an antibody, and you target something. This is Dr. Kalbasi, who's running a trial looking at a specific target in melanoma, allowing brain mets. And this trial, I believe, is fully accrued or near accrued. But why do I say that? Because you can learn a lot by going to other meetings. And this is stuff from Stanford, giving a lot of shout outs to Stanford. But this was a phase 1 trial for the feasibility and safety of CAR T cells. And the CAR T was given in 2 ways. These are for low-grade gliomas. They were given traditionally IV. You admit the patient, you give CAR T IV like we do for B-cell ALL and others where it's standard. You give it IV. But it had an arm that looked at, if you look at the bottom, the optional ICV. So that's giving it intracerebral through an Ommaya reservoir. And what did they see there? This is hard to get, but you see these, the darker orange. When you gave those CAR Ts directly into the central nervous system, you saw less toxicity, you saw more activation, and they showed me this, which was amazing. A near complete response, 7 infusions, response durable 11 months. That's cuckoo crazy, lovely stuff. And there's no reason that this can't be done in melanoma or other solid tumors. NK cell therapies, it's just suffice it to know that NK cells are other types of immune cells. They're not T cells or B cells, but they're other immune cells in your body. The great thing about NK cells is that you can give them to anyone. They're not you don't really mount an attack against it. And NK cells can be grown to a point where they can be given hundreds or thousands of infusions from just one donor. NK cells can be given from the patient to themselves, an auto NK, and they can be given allo NK. Allo NK is from someone else. And the newer therapies with NK cells don't need pre-medication. They don't need a preconditioning regimen with chemotherapy. They don't need hospitalization. They don't need an adjuvant like high-dose IL-2. You could give it in the clinic. And that's amazing. The patient can come, show up in your clinic, and be signed up to get this therapy right away. There's no harvest, nothing, off the shelf, ready to go. And this is amazing, amazing work that's being done by multiple people and being done by some of my favorite people. This is SNK. This is their data. I believe this was lung cancer with auto NK, but in patients that were PD-L1 negative, that were unresponsive to PD-1 therapy, and they've shown responses in lung cancer and sarcoma. Talk about an immune desert, something that doesn't respond. That's sarcoma, and we're seeing NK cells work well. I did put a slide? I did. There are multiple trials going up in this. Here's one of systemic NK cells and temozolomide for stage 4 melanoma metastatic to the brain. So it's coming and it's already here. These bispecifics that are approved for ocular melanoma, I just want to make a point. I call them a matchmaker or Yenta antibody. It's 2 sides. One clamps onto the T cell, one clamps onto the tumor, brings them together and says you two should meet. And it's a very bad relationship. The T cell kills the tumor. It works well. It's a homing mechanism, and we think it's great for those patients who can't get the T cells to the tumor, and there are trials looking at this with PD-1 in multiple solid tumors. We know that it traffics the lymphocyte into the tumor, pre-treatment, post-treatment, and this is one that targets a PRAME and not the one that targets GP100. You don't need to know that. But this was data that came from MD Anderson. That's based on work from Dr. Nieto and my favorite Persian doctor, which is Katia Rezvani. They're taking NK cells from cord blood, and they're growing it up, and they're also they're weaponizing it by adding a bispecific that binds to the NK cell and takes it directly to the tumor. And there's no reason that this can't be given. All right, so as I come to the end of my talk, a couple points to be made here. You need a multidisciplinary team. And it just doesn't have to be in one place. I have privileges at 3 separate hospitals and work with their radiation oncologists, the neurosurgeons who need to come in at times to help us get the patients through therapy or get them to the next therapy. There needs to be a patient advocate, a social worker, a palliative care person, a nurse practitioner, etc. So this is the multidisciplinary team, but I love this because it reminds me of Howard Scher. And Howard Scher, none of you know because he takes care of prostate cancer, but he's at Memorial. And I went to the Prostate Cancer Foundation to talk about anti-CTLA-4 a long, long time ago, and he talked about not thinking about it as the elephant in the room. You have to think about it like there's a stallion in the room, that you have to grab this and ride it to success. And that's the way that I think of my patients when they come in. There's no reason why they cannot benefit, like the lovely patient here who was on the Sparkle study that asked the questions. And so at the conclusions, improved survival for patients, many new pathways, many new agents. Their second line is expanding as we're improving the first line, as we're adding more in, because that's a paradigm for all solid tumors. Breast cancer, you treat with three chemos and go on. Why not treat with so much more in melanoma? There are options for brain metastases, and of course, why we're always here, clinical trials, clinical trials, clinical trials, clinical trials. An invitation if you're in LA to come visit us, and I thank you for your time, and we'll take questions.
So we do have time for some questions. If anyone wants to raise their hand. Yeah.
Hello, Dr. Hamid, my favorite doctor in LA. He does happen to be a doctor of mine. I just wanted to go back to one of your initial slides, the publication, I think, from the 1970s, that showed such a difference between the sort of autopsies of brains of patients with cancer showing disease versus what had actually been diagnosed. That's quite a scary thing for me personally, to think that maybe my MRIs are not picking up everything that could be lurking there. How do we solve for that? Is it through higher resolution imaging? Is it through AI interpretation of those images? Is it better therapeutics? I'd just like your thoughts on that.
Yeah, so I think it's all of that. The good answer is all of that. Number one, I'm going to call all the other doctors that are on your care and let them know that you said I'm your favorite. Number one. Number two, one thing to know is what we've shown is what's happening here is what's happening everywhere. So if you see things go away, you know that that's working in other areas. We know this. This is why you get meningitis. There's an immune system specific to your central nervous system. That's number one. Number two, I have a lot of favorite Howards. Another favorite Howard of mine is Howard Sewell, who works at the Milken Institute, which is intimately involved with MRA. But he's told me that there are 8 Tesla MRIs, so better MRI that can pick up even Lewy bodies, early Alzheimer's, stuff like that. So radiologists are improving their field. Radiation is improving. One of the other things that I would say to you is the way that we take care of brain mets is improving. I didn't put a slide up there. And it melds into a couple things that Mike Atkins says. Neoadjuvant therapy is not just for local therapy. It's for therapy anywhere. But with the local therapy, you can find predictors to response, prognosticators for outcome, and you can utilize that to pick the right therapy in the first line for our patients. So those have taken the place of autopsy studies. We want tissue to know what happens, how we change the microenvironment, what works and what doesn't. We want to find, I always used to talk about exceptional responders. Why was that person such an exceptional responder? We never could do that. And now through neoadjuvant studies where you give the therapy, you pull out the tissue and you see, oh my God, it's all gone. There's something on the x-ray, but it's all dead. You know, you're familiar with that paradigm. And we can then go to the patient and figure out why. Why did this group of patients do well? And then we can examine them head to toe. What color hair do they have? Where do they come from? What are their genomics? What do they like to eat? Blah, 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 blah. And then hopefully utilize that to give you the peace of mind that you need. There was data in recurrent glioblastoma. So I didn't mention glioblastoma. Recurrent glioblastoma. If you gave a couple of cycles of PD-1 therapy and then did the surgery versus just doing the surgery and giving whatever, it was better outcomes. So I believe that the neoadjuvant paradigm is here to stay for multiple solid tumors, and we've gone heavy into opening those trials.
I think we have another question over here. Jamie, your hand was up. Oh, okay. Sorry. Was there a question over here? Okay. There you go. Thank you, Dr. Hamid. I made sure to let Dr. Taubi know that you gave him a shout out here, just so my question is, you know, you talked about some of these combination of therapies with the brain, but do you find that starting treatment and then doing cyberknife radiation has a better result, or is it usually the other way around?
Right, so we don't have quite that answer. What I have found is that in patients who have asymptomatic brain metastases, specifically because the Sparkle trial, 204, didn't allow radiation, that I found that patients who got treated after a couple cycles and you looked in and they were responding never really needed radiation, so that we can avoid that toxicity. We've also found that radiation can act as to release tumor antigen and may help immunotherapy work better. So and we've also, one of the things that you need to, why we have multidisciplinary teams, because you can tell the radiation oncologist, very safe to give radiation with immunotherapy. Not so safe to give it with targeted therapy. So for me, it's helped us to know when and how to utilize it and how to avoid toxicity, because quality of life is important also. And there are two misconceptions. One is that melanoma is not radiation sensitive. It is, we've seen it. And the second is that radiation is non-toxic. It isn't, I've seen it. So it's helping us to be able to shape a therapeutic paradigm, and this is another thing, bespoke for the patient, like a suit, bespoke, that utilizes each of our tools at the right time. Okay.
I have a question, and this is not something you have specifically addressed, but someone mentioned earlier that a lot of the cutaneous melanomas are caused by sun exposure. Where do they come from in people who are not outdoorsy, that don't spend any time outside?
Cutaneous melanomas? I can't answer pediatric.
Okay, this
I
is
mean,
not...
the genetic predisposition.
Yeah.
I will say we're making inroads there. Most of the trials now are allowing younger patients, and they're showing the same responses and safety. In the others, I would say that there are, I don't have the greatest answer for you, but mutations from other events.
All right, I think we have time for one more question, if anyone. I see Jamie.
Would that be like epigenetics getting involved in it?
Yeah, because we know epigenetic therapy, like methylation therapy, has some responses in that, and that's work that comes to mind when we talk about like Ryan Sullivan and some of that work.
sorry. So my question is, you mentioned using cord blood in one of the NK for the stem cells. Was that, I'm just interested to know, was that cord blood used, was it in any way related to the patient who got it, or it was
Not
just
related to the
not
patient
related?
who
Okay.
got it.
Interesting.
Yeah, it's great. The best part and the worst part of medicine is finding amazing therapies that just blow your mind and give you the energy to move on and to know that there's more out there and more to offer. That's also the worst part, because you realize you're not doing that amazing work. And so you get on the phone with Bella Glitza and Kathy Rizvani and say, I'd like to start an intrathecal NK trial for melanoma. And they say, oh yeah, we're doing this in other solid tumors, why not melanoma? And that trial is coming. All right, I've taken too much time.
Thank you, Dr. Hamid, for a great talk.